Uh, Welcome, friends. Uh, you, I welcome Dr. Gurmeet Singh from Bhilai. Uh, he will be taking the next lecture on bone marrow examination. We are very grateful to him to have accepted to present this talk. Dr. Gurmeet, you can start now.
Thank you, sir. Bone marrow examination, as we all must be doing it regularly. Now, these are a pretty basic things in which I'll cover what the cells look like, what are the things that should we keep in mind while reporting a bone marrow. And we'll start with what are the indication of it, how to do a bone marrow. Uh, the needles, I'll show you some of the needles that are used. We'll basically talk about the aspiration only today because covering the bone marrow biopsy is a bit lengthy thing and it will again confuse, will mix it up. And most of us generally do only a bone marrow aspirate. And once we are comfortable with it, we can talk about the biopsy also probably uh, sometime next time. This shows just
Dr.
the
Gurmeet,
general
can you
indications.
do something
Sir,
about your voice audio? The audio is
is it now?
quite low.
It's clear now?
Yes, now it's better.
Yeah. So the indications are pretty much clear. There are some red cell indications. Depending on the line that are involved, we can divide it, say the red cell indications, the white blood cell indications, or because of the problem in the megakaryocytic lineage, that is the platelets, whether they are less or more, as in case of ITP, if more than in the case of uh, essential thrombocytosis. Myeloproliferative neoplasm sometimes to diagnose storage diseases, especially in young children, other malignant conditions like multiple myeloma, the Waldenström macroglobulinias, to look for metastatic deposits or to rule out the bone marrow failure states. This is a aspirate needle that is used nowadays. It's a disposable one, the modified Sala needle. Most of us probably would be using the reusable one that we were using earlier. The important thing is that it has a lock, so that this is the lock, and this prevents from excessive the needle from going too deep. The lock or the guard, as we say, the guard was very important during the days when the most common site to do the bone marrow was the sternum, because it used to help us a lot. I also learned doing my bone marrow right from sternum, and it's pretty easy to get from there for us. But now sternum is not the preferred site. We use posterior superior iliac spine as a most common site, since it is easier to do, it is more safe, and if we need a biopsy can be taken in the same sitting. The needle that is used for bone marrow biopsy is the Jamshedi needle. This is the Jamshedi needle, which is a disposable one, and see here three parts. This is the needle, this is the stillet that is inside, and this is again a very thin stillet which is used to get the bone marrow refined biopsy piece out of the needle. The most important aspect is that when once we have taken a biopsy, this needle goes from the end which is open, and the biopsy should be pushed this way and come out from here, because if we push the biopsy in the opposite direction, the edge, which is a beveled edge, this will cause a crush artifacts. So it is very important that biopsy should not be taken out from the end which is the beveled end. Once a procedure is planned, there are three things that we can do with these are the three samples that we get. That is an aspirate sample and a refined biopsy sample. And from that refined biopsy, we can get a touch smears. Now, aspirate is the first thing, ideally, it is the first thing that should be done before taking a biopsy because if we take a biopsy first, there is a lot of hemorrhage and that may dilute the sample. There is a school of thought which says that refined biopsy should be taken first because it prevents the artifact that is induced because of the aspirate. Um, the important is how much of bone marrow is to be aspirated. In a routine smear, when we don't have to go for any special studies, less than 0.5 ml of bone marrow should be aspirated because if we get more than that, it will be diluted and the true representation would not be there. So less than 0.5 ml, that is as soon as you see the bone marrow in the hub of the needle, take it out, push the sample out on a slide and make smears. Now smears for bone marrow are to be made as they are made in a peripheral smear of a blood because and not as we do it in cytology because that may cause the crush artifacts and cell morphology is generally lost. If special studies are to be done, like in cases of acute leukemia, then first zero point 0.3 or 0.5 ml of blood should be aspirated for direct smears. Then we should take more blood for various studies in anticoagulants. Like if we have to do a flow cytometry and we have to do a cytogenetic study, they should be taken either in a heparin container, heparin tube, or in a EDTA. And it depends on uh, what is the test to be done. Now these smears are generally stained with a good quality stain, whatever you prefer. I generally would suggest that for bone marrows one should use GEMSA stain modification of GEMTA, that is the MGG that is generally used for our cytology slides because they give better results. The granulation in the bone marrow aspirate and the nuclear details, they are more clearly visible when we use either an MGG or a Jenner GEMSA or a Wright GEMSA, whatever you can make for yourself. Now these smears can be used for cytochemistry, so make as many smears as possible from the sample that you have got. And while staining, at least 3 to 4 slides of a bone marrow is to be stained along with a peripheral smear. Looking at a bone marrow without a peripheral smear and a CBC report is worthless. It won't give us much of an information unless it's a very clear-cut case of say acute leukemia. Now sometimes it so happens that while taking out the aspirate, we get the bone marrow clots inside the needle. So in such cases, the clot should be given for a section and histopathology, so that we can make a clot section. If there are cells entrapped, we can perform IHC if required. The second is a refined biopsy specimen that we get, which should be made into a touch smear. I have a video that we have made to be published with the Grucci textbook of hematology that was recently, a couple of years back it was not. So what I will do is I'll send that video to the group and you can see how to perform a bone marrow aspirate and a biopsy. So that will make you understand things a bit easier for you. Now, from the touch smears, we can, from the defined biopsy, we can make touch smears, and those smears can be used for differential and for various staining. This is how pretty much bone marrow aspirate preparation looks like. The certainty when it is in bone marrow is by looking at the megakaryocyte. This is the large cell, and looking at the particles, the bone marrow particles. If we don't get the particle, then also we have to look. Sometimes if such happens, the particles are not there, but then the cellularity is good, and we can do a good differential on it. That is good enough. This is how a touch smear looks like, a refined biopsy after it's been processed, and a cloth section. So there are four things that we can see, we can get from a single aspirate and biopsy setting. Uh, Aspirate, a touch smear, a refined biopsy, and a cloth section. If possible, I would suggest to do a bone marrow aspirate and biopsy in the same setting. Sometimes we have to do a second marrow, and if we have a biopsy, that need for that second marrow is we don't need to do a second marrow because we already have a material which we can look at. Now coming to the bone marrow aspirate problem. The bone marrow aspirate can be dilute at times. If it is dilute, it could be because of our fault in our procedure, and secondly, it could be because of the marrow fibrosis. In both the cases, a bone marrow biopsy is indicated, and so if we have a biopsy along with it, we don't have to repeat the procedure. This is in just the cells that are seen, the erythroid and the myeloid lineage of the cells. We have the lymphoid cells, the plasma cells, the megakaryocytes, the histiocytes, and some other cells. We'll look into it one after the other. This is just to give an idea of what the normal development of the cells, what are the types that we have to look in the bone marrow. We'll come to them individually, each individual cells one at a time. Once we get an aspirate, we first have to look at the particles and assess the cellularity. The cellularity, assessing a cellularity on aspirate is tricky one. It's just a relative thing. An actual assessment of cellularity is always given from a refined biopsy using a histomorphometry. But with experience, without histomorphometry also, we can give a rough estimate what is the cellularity in a refined biopsy, looking at the cellular spaces along with the fat spaces and the ratio of both of them. In an aspirate, it comes with time. If we see more number of cells, if the particle is very cellular, we can say that cellularity is adequate. Or it is mildly diluted or fairly diluted, the terms which we can use. We should never give the percentage on an aspirate. After looking at it, next step is to go for a differential count. And on a bone marrow, a differential count should always be done on a 500 cell count. It should never be less than that because that reduces the error bias that we can get looking at a particular area. See, the bone marrow is very cellular. It's in this slide. The bone marrow is very cellular, and so if we don't do more, if we don't count more number of cells, we will be getting a very less representation of the actual tissue. So counting is very important, and the second part is how to select the area from which a differential count is to be done. Here we see a bone marrow slide, and these are the particles of the bone marrow. So ideally, counting should be done on these cell trails. This will give exact picture of the different cells in different proportions present in the particle of the marrow. See here, this is a very cellular particle, and the cell trails we have to count. Now, before counting a cell trail, we should again choose an area. Cells are very well preserved. See, on the looking at us low power, both of this area look same. But when seen at a higher power, this shows only bare nuclei. No cytoplasm is seen here. Whereas this shows there are a lot of there is a cytoplasm, and so identification of cells would be easier in such areas. So we have to use a well-preserved area which has well-preserved cells for our differential count, and it should always contain a differential of 500 cells. Along with it, while counting, we should always have a history, the clinical details, and as I said, a peripheral smear. Before counting a marrow, you should do a differential on the peripheral smear, do a PS reporting, and then start counting the bone marrow. The number of slides that has to be stained is always 3 to 4 slides, and ideally, after doing a differential in one slide, we should look at other slides also, so that we can get a fair idea whether the distribution is equal or not. Sometimes it does happen that one of the slides shows, especially in a metastatic, if you want to rule out metastasis, that one of the slides would show a tiny metastatic deposit while others would not. So we have to look for as much slide as possible. Similarly, if we are looking for an antibody, say in a case of induced splenomegaly and leishmaniasis, suspected leishmaniasis, we should always stain more number of slides. After doing the differential count, the thing that we should calculate the myeloid to erythroid ratio. So this myeloid to erythroid ratio would include all the myeloid lineage of cell, including the mature ones, the neutrophils, the monocyte, monocyte precursors, the eosinophil precursors, the neutrophil precursors, and on the other hand, the erythroid precursors. Now coming at the type of cells and looking at them individually. So the myeloid precursors first, because they are generally more numerous. The myeloid precursors start from myeloblasts, then promyelocyte, myelocyte, metamyelocytes, and then the mature neutrophil. So here is all the cells in one slide. These are taken from a peripheral smear, so they are very separated from each other, but this is just for identification. In next slides we'll see and how they look in a bone marrow and how close they are. So this one is the first number one is a neutrophil, second one is a metamyelocyte, the third one is a myelocyte, the fourth one probably a promyelocyte because it has still a nucleus in it, a large abundant cytoplasm in it, and then there is a blast. Now this is how we see them in a bone marrow. They are very close to each other, and sometimes when we see too many cells together, it is difficult to differentiate, and moreover it becomes difficult from where to start accounting and where to end. So always make it a point, make it a habit that you start from one point, whatever you are comfortable with, whether it's a 6 o'clock position or 12 o'clock position, and go on counting all the cells until you reach back to that position. Because initially, when we start counting the cells, this is a real problem. This is a problem which first year PG always faces when we start seeing the marrow. Confusion. And second problem is the bias that he had. Bias because he would count the cells that are very easily identified by him and would then leave cells which are not easily identified. And that way, that would be there would definitely be a bias in his counting. So here we can see a mature neutrophil, metamyelocyte, and myelocyte. Now, how to identify a different cells? And this is a blast, and this is a promyelocyte. See the difference. The promyelocyte is larger than a blast. It has more cytoplasm. It has more of granules and a very clear-cut Golgi shape. The blast has a condensed cytoplasm and the scanty to moderate amount of condensed nucleus and a scanty to moderate amount of cytoplasm depending on which type of blast it is. And this is generally a first recognizable cell in which the granulocytes. Generally, the blast size is around 3 times that of a RBC, that is around 15 to 20 micron. And the important thing is that the nucleus may be very irregular in shape. The chromatin pattern is generally diffuse and there are many nuclei. Most of the myeloblasts, they lack granules, but there are some blasts which may have prominent granules also. These myeloblasts, they can be, according to the earlier FAB classification, they were divided into three parts. That is the type 1 blast, type 2 blast, and type 3 blast. Type 1 blast does not have any granules. Type 2 blast has some granules. Type 3 blast has plenty of granules. That is, type 1 will have primary granules. Type 2 will have a secondary granules. Now next comes the pro uh, promyelocyte. As I already said, it's a large cell, larger than the blast, and it has lots of granules and a prominent conjugal. See here again, a promyelocyte, a metamyelocyte, and a myelocyte. So the three in the same picture, and so we can differentiate it very easily. The the way I used to remember during my early days was that the promyelocyte will have a nucleus which is round in shape. Most of the times, a myelocyte will have a nucleus which is D-shaped, and a metamyelocyte will have a nucleus which is B-shaped. That is, there is an indentation. So as soon as an indentation starts, we can say that it's a metamyelocyte. And the chromatin pattern goes on condensing. Here we can see the blasts have an open or an immature type of chromatin. As we progress to the myelocyte, it becomes more condensed. We can compare it with lymphocyte. Although myelocyte is still open up, but it is more condensed than that seen in a blast. The myeloblast generally has nucleoli 2 to 4 as it is 7, but that's not a rule. Sometimes you don't even see a single nucleoli. But if they are present, they are helpful in identifying. These again are various cells, various patterns. The blast, this is also a blast here, a blast here. So various types of blast that we can get. These are the myelocytes. Here we can see the eosinophilic precursors. Sometimes we get lot of eosinophilic precursors. A eosinophilic metamyelocyte. This is also indentation is there. So eosinophilic metamyelocyte. This is a myelocyte, normal myelocyte. This again is a metamyelocyte. I deliberately took a lot of pictures so that we can just have a look at what do they look like. Now coming to the monocytic lineage. Monocytic lineage are very difficult to adjust because the difference between a pro-monocyte and an atypical pro-monocyte is very subtle. And you need to look at it again and again so that you are confident that yes, it is a normal pro-monocyte or a normal pro-monocyte. A sir has sent a very beautiful paper on monocytic identification a couple of days back. I suggest that all of you should read it thoroughly. I will show you some of the pictures from it. It's a wonderful paper, and reading through it will probably clear a lot of doubts. Here we start with a, a normal monocyte. This is a normal monocyte. And comparing it with a promonocyte. See, the promonocytes, the, the cytoplasm is still the same. Light blue, sky blue cytoplasm, but there are a lot of vacuoles also. But the nuclear foldings are very prominent. So this helps us to differentiate it from a monocyte and also from a monoblast. The monoblast has a large, it's a large cell. It has a large nucleus. Sometimes a number of vacuoles are there in the cytoplasm, and there are we can appreciate granules at times. And it differs from promonocytes in that it generally lacks uh, the nuclear foldings. Now, for the sake of counting the promonocyte and the atypical promonocyte, the monoblast, are all counted together as a blast equivalent according to the WHO classification. So here all the three cells in the same picture. That is a monocyte, this is a promonocyte, and this is a monoblast. Here again we can see a promonocyte, and this is a monoblast. Here there is a clefting in the nucleus which is sometimes seen, and prominent nuclei. This is a definite monoblast. Here again, when in confusion, we can do a special stains, that is the NSC, which will stain the monocytes. To differentiate it from promyelocyte, the promyelocyte will have lot of granules, and but the promyelocyte a lot of granules. Promonocyte will have nucleus which is very irregular with a sky blue cytoplasm. This is what I was referring to. How to evaluate a monocyte in a bone marrow or a blood smear. So they have divided them the cells into monoblasts, the promonocyte, the immature monocyte, and the monocyte. But look at the shape of the nucleus, that is round to oval. Here, promonocyte, it would be convoluted and indented. Immature monocyte, convoluted and indented. So that to differentiate between these two, it becomes very difficult. It needs a repeated viewing at the cells so that you can be confident for what you are actually looking at. This is a pictorial representation. This is what I was talking about, the immature or the abnormal promonocyte. Now, these, along with the monocyte, are considered to be a blast equivalents. These, along with the blasts, monoblasts, are considered to be blast equivalents for the sake of counting according to the WHO classification. Now coming to the lymphoid cells. This maybe we will just have a look at a couple of slides of this, because this itself is a very big part, and we need we will probably need more time to look at different cells of this. Now the blasts, the monoblasts and the lymphoblasts are most of the time confused with the hematogones. Hematogones are very blast-like cells which are present generally in the marrow of the children. Especially if someone gets to look at the marrow of ITP in children, you will come across a lot of hematogones. And once you start looking at them, you can distinguish them from blasts. Sometimes it becomes difficult, but the difference that what we look at it is that hematogones generally has nucleus which has a bit of a glassy appearance compared to that of a blast, the lymphoblast, which is a bit opened up. So, but the only way to differentiate the hematogone from a lymphoblast is by doing a flow cytometry, in which we get a very classical cascading pattern using the CD10 and 20. Now this is very important. We have tried precursors, because I hope malaria is some anemia is something which most of us look. Megaloblastic anemia, the cause of marrow, is very common in most of the people. When we look at the various erythroid precursors, we have the erythroid. It starts from the erythroblast. That is the early pro-normoblast. After that comes the basophilic normoblast, the polychromatophilic normoblast, the orthochromatic, and then the RBC. So the pro-erythroblast or the pro-normoblast, they are large round cells, and diameter of say around 15 to 20 micron. The cytoplasm is generally very deeply basophilic, so we can separate it from the blast, the myeloblast. And there is a clear-cut Golgi zone which is apparent because of the deep basophilia of the cytoplasm. Nucleus is finely granular or stippled, and it contains nuclei which may range from 1 to more than 1. As they reach the early erythroblast stage, that is the basophilic normoblast, they become a bit smaller. The, the nucleus or the nucleus to cytoplasmic ratio becomes somewhat lower. the cytoplasm is still very basophilic, and the nucleoli is generally not visible here. Now, if we look at the polychromatophilic normoblast, this is the stage in which we can identify that hemoglobin has started appearing in the cytoplasm. So that gives that polychromasia, feeling of dual color in the cytoplasm. And the nucleus is more condensed. There is clumping of the nuclear material. And in a late erythroblast, the they are the most numerous in the bone marrow in the erythroid series. They are slightly larger than the red cells, and the NC ratio is lower than that of both intermediate this erythroblast. The cytoplasm has become more pinkish tinged, that is very near to that of a reticulocyte, and because of the increased hemoglobin. And the nucleus becomes pycnotic, less uh, collected at the one side. Now this shows the cells seen in the marrow and the peripheral smear. This is the nucleated RBC that we see in the peripheral smear. These are the nucleated the erythroblast that we see in the marrow, and this is a large cell, and that is the proerythroblast. Here again the erythroblasts in the marrow. Here we can see the late normoblast and the early normoblast or the basophilic erythroblast. We'll see a case here. A 9-year-old child who was admitted with pallor is a known case of ALL and was diagnosed 6 months back, has been on therapy since then. He is on maintenance now, but he suddenly presents with anemia and is given hematinics. There was no response. A retic count was done, which was showing a 0.2% of retic. A clinical diagnosis of relapse of ALL was made, and then bone marrow was advised. Now this is the bone marrow picture. What we can see here is, in this whole picture, there is a paucity of normoblast or the erythroid precursors. There are actually very few of them. Most of the cells that are seen here are of the myeloid lineage. Now, in a case of anemia, what we generally expect is that the erythroid cells will be more in number, but here to the contrary, they are very less. In such cases, we should always think of red cell aplasia, pure red cell aplasia, and search for such large erythroblasts, which are generally seen because of a parvovirus infection. Now, although the nucleolus is not very clear in this cell, I'll show you next step that the nucleolus is clear. The cytoplasmic projection along with the nucleoli gives it an what we call as a dog's appearance, dog ear appearance. Now, this is showing the very prominent nucleoli. The lower slide is of a biopsy specimen, and here also we can see a prominent nucleoli. So in cases in which we anemia, in which we expect an increase in erythroid cells, if we don't see it, uh, we should specifically look for causes which can lead to PRCA, and parvovirus 19 is one of them. In other cases, when we get a lot of erythroid cells, we should look at whether they are on in various stages of maturation or not. Because sometimes the viral infection can lead to a maturation arrest at very early stage also. So that would help us in distinguishing the type of anemia. This is a slide from megaloblastic anemia. This is, I think, the most common indication of bone marrow in some parts of the country, including where I live. And uh, it is something when we see a lot of erythroid cells, we jump to a conclusion that they are megaloblastic. But here what we see is that most of the cells are early erythroid cells. These early erythroid cells are not to be confused with megaloblastic. then megaloblasts will have an open seed-like chromatin, and there will be cytoplasmic nuclear asynchrony. Here we can see that the cytoplasm, and here we can see the cytoplasm is almost that of a reticulocyte, but the nucleus is still very large. So such are the things which are the cases, such cells will help us in cleansing the diagnosis. This is a case from Marrow from an iron deficiency anemia case. Here we can see the spraying of the margin of the erythrocytes. And the dimorphic anemia in which we get two different type of erythroid cells. This is one normal with fraying of micronormoblast with fraying of margin, and these are the normal macro the megaloblasts here. Here. So dimorphic anemia may have both of them. So looking at another case of this was of a 14-year-old child. He had pallor since childhood and requiring repeated transfusion, mild jaundice and hepatomegaly, but marmocytic normochromic blood picture. Now, bone marrow was done, and some classical cells are seen here. The binucleated erythroid cells. Now, such binucleated erythroid cells are a very characteristic of CDA. And if both the nucleus both the nucleus are joined by a thin strand, and they are of the equal shape. That we say both the lobes are of equal size, and classical dumbbell shaped nuclei that we say, it is generally seen in CDA type 1. In CDA type 2, although there are two lobes in the erythroid nucleus, the normoblast, but they are generally of unequal size, and we are not able to visualize the thin strand between them. Although CDA is very rare, but we should keep it in mind once we are looking at a marrow. What I feel is that CDA is underdiagnosed because most of us we don't have a very confirmatory test which can stamp it at CDA. These are the type 3 CDA cells in which there is multinuclearity in the erythroid precursors. Again, a type 3 CDA cells, this shows multinuclearity in the erythroid precursors. The other thing that we have to do once we get the bone marrow is always do a iron stain. Make it a habit to put up an iron stain in each and every case, whether it is of a leukemia or anemia or something else, because that way it helps us in two things. First, we get a control from cases in which negative iron is there, because for iron a control slide should always be stained. If a control is positive and your slide is negative, the patient slide is negative, then only we can say that the patient has iron deficiency anemia. Otherwise, it's of no use, because there are lots of procedural artifacts and procedural problems in which iron does not capture stain. So that gives us a positive control. And second is sometimes we pick up things that we don't expect to see, like the sideroblasts in case of an MDS. And once an iron stain is done, we should know how to grade it. WHO has given a grading of iron from 0 to 6, and in this grading 0 is no iron and 6 is excess of iron, and it should always be reported as WHO grade whatever it is seen. For the abnormal sideroblast, these are the things that we can catch if we are aware of it. Looking at this, the sideroblast is is a cell in which there are at least five and five iron containing granules which are surrounding the nucleus, covering more than two-thirds of it. That is a classical definition that is given. And ring sideroblasts are seen apart from the the congenital sideroblastic anemia. It is seen in case of MDS, and more than 15% of ring sideroblast is a criteria for classifying it as refractory anemia with ring sideroblast. Now coming to the largest cell of the bone marrow, that is the megakaryocyte. Once we look at a picture, bone marrow aspirate, the first thing that we see is a megakaryocyte because it is the largest cell and can be identified easily. So once you are scanning the whole slide, you should make a note of it, whether megakaryocytes are seen or not, what is the distribution evenly or are in clusters, and then we can go ahead. Sometimes a large platelet precursor is also seen, that is a proplatelet can be seen in the peripheral sphere. Here it is again a proplatelet which can be seen in the peripheral sphere. This is just to show this is a platelet satellitism, as we all have, we all know, just it is because of an UDT artifact and clumping around the neutrophil. Now, I want you all to guess, just keep in mind what this cell is. What this cell is. If we compare it to the last picture, the platelets are surrounding a cell. Now, here we can see a basophil. So, we can this cell is a micromegakaryocyte. Presence of this micromegakaryocyte is generally seen in CML. It can be seen in peripheral smear. And whenever you get a slide of a new case of CML, try looking for it. You'll definitely guess this micromegakaryocytes. This is again a low power view of a megakaryocyte, a high power view in which you get the basophilic cytoplasm, and we can see platelets coming out from it, the irregular margin with the platelets coming out of it. Here again the same. Now, as I said, one should look at the number and distribution of megakaryocytes. Generally, they are seen scattered, large cells, but sometimes they are in clumps. Now, this is a mature megakaryocyte which is lobulated, a large amount of cytoplasm with frayed edges, and we can see platelets coming out of it. This is a megakaryocyte which is seen generally in a case of ITP. Such megakaryocytes are a bit smaller. They have a single lobe nucleus and are more basophilic, and they are known as young immature form of megakaryocytes, most commonly seen in ITP cases. To recapitulate the various forms of megakaryocytes that we can see, this is a normal megakaryocyte. Here we can see multilobulation, abundant cytoplasm. This is again a megakaryocyte, but in contrast to the picture A, the picture B shows large, more number of lobulations. This is classically seen in cases of essential thrombocytosis, and we call it as bulbous, cloudy or bulbous presentation of megakaryocyte. Here we can see a classical emperipolysis. It is not uncommon, we can see it many times. An intact cell inside the cytoplasm of a megakaryocyte. And if while making a smear, if our hands are very hard, then we can push off this cytoplasm, and what we get here is a bare nuclei of a megakaryocyte. So these are the normal distributions, and here are the dysplastic megakaryocytes. We'll see to them again, but these are few of the dysplastic megakaryocytes. This is a classical megakaryoblast, a central round cell with a prominent nucleoli and levy. This is a dysplastic megakaryocyte, hypolobulation, single lobe. This is multinucleation. See, here we have multiple lobes, but here they are multinucleation. Everything is separate. This is a characteristic of this megakaryopoiesis. Now, some of the other cells that we generally see in osteoblasts in the bone marrow are the osteoblasts, which are generally confused with the plasma cell, and that is why I've put both of them together. The osteoblast will have a nucleus which almost extrudes from the cytoplasm, and a half which is generally distant from the nucleus. And in a plasma cell, we have a nucleus which is eccentric with a knob with a half. The osteoblasts are generally seen in clusters. There's another cell that we generally see is an osteoclast. So they are a multinucleated cell and they have to be differentiated from megakaryocytes. As mentioned, megakaryocytes are some which shows multilobulation, not multinucleation. Now looking at some of the dyspoetic cells, this is a normal bone marrow showing normal erythroid cells, and here we see on the right side the dyspoetic cells. The dyspoetic erythroid cells, they are showing nuclear budding and irregular nuclear contour, and these are the features of dyserythropoiesis. The nuclear budding, multinucleation, irregular nuclear contour, cytoplasmic vacuolation, then ring sideroblasts. These are the features of dyserythropoiesis. This is a classical dyserythropoietic metamyelocyte, the normal myelocyte and a dyspoetic myelocyte. This again is a feature of dyspoetic megakaryocyte. Just to give a schematic representation how a normal erythroid cell, a megaloblastic, and megaloblastic with dysplastic erythroid cells are different. So here in the middle one we can see megaloblastic features, but in the here these cells, apart from the opened up nucleus, we see irregular nuclear contour along with this budding. So these are the features of dyserythropoiesis. Here we can clearly see the late normoblast showing multiple budding of the nucleus. Again, all the three cell lines together, the megakaryocytes. This is a bulbous. This is multinucleation. This is characteristic of 5q. In erythroid cells, the ring cytoblast, the nuclear budding, and in the granulocytic series, there is loss of granule in the cell. We will now see a couple of cases so that all types of blast and other cells that we have seen as we can see here. This was a case of a 6-year-old boy with fever of 1 month duration, and we can see classically the blast. This is a very large cell. This is also a blast with vacuolations, and here is nuclear molding. So we can be sure that this is an acute leukemia. Similarly, a case which shows blast along with uh, these structures are generally, they are known as 5 bodies. They are fusiform or elongated shaped bodies derived from lysosome, and they are peroxidase positive. And they are very characteristic of myeloid leukemia. Just like OR rods are characteristic, 5 bodies are also characteristic of myeloid leukemia. This is again a case in which we can see a lot of blast together almost with no maturation. Here a blast showing the OR rod. Presence of an OR rod generally is always indicative of a myeloid leukemia, and most of the time we don't need help of anything else. This is a slide which shows various a lot a number of OR rods in a cell, and this is a classically bilobed nucleus which are overlapping each other, abnormal localization of granule, and this is a APML case, that is AML M3. Here again, bilobulation, abnormal granulation. The granules are so much so that they cover the boundary between the cytoplasm and the nucleus. nucleus, and it is impossible to distinguish. And such that is a classical definition of an abnormal promyelocyte, so that we can differentiate it from a normal promyelocyte. And these collection of R rods are known as faggots. This is again a monoblastic cells showing nuclear irregularity, indentation, again a monoblast, and a cytochemistry showing positivity for NSC. These are the plasma cells. Here we can see the quality is not very good. I'm sorry for that. The plasma cells, a binucleated plasma cell, so most of the time they are seen in multiple myeloma. Here in a high power, you can appreciate that. This is a very classical picture of lymphoid cells showing a lot of vacuolation. Most of you must have guessed it. It's a L3 type of blast. There are some times when we have to be vigilant on not only the blast percentages but other things also. Here is a case of a 23-year-old boy who was admitted with fever and cough. He showed X-ray consolidation of left lower lobe on X-ray, a TLC of 1100 with lymphocytic predominant, and a bone marrow was done. So what we see here is a bone marrow slide in which there is a paucity of metamyelocytes. All the cells are from the myelocyte stages and above. When we compare it with the normal bone marrow, we can see that neutrophils and metamyelocytes and staph cells are seen here, but here we don't see. So this is a case of a maturation arrest. When we do a differential, we should always, in all the cases, we should do a very thorough differential and should always keep in possibility such things that we don't generally see regularly. Now, few of the parasites that we see, here are the antibodies. It is generally seen inside the histiocyte. The histiocyte cytoplasm is full of antibodies, and this is the histoplasma. The metastatic disease is something which we come across once in a while, and sometimes the lymphoid aggregate looks as sometimes the marrow cells look like they are of carcinoma cells when we are suspecting a metastasis. So there are some points from which we can differentiate. The carcinoma cells are generally found in cohesive clusters, whereas in hematopoietic cells form a very loose cluster. And on seeing on a high power, we can see the smooth boundaries of the cells, and there is molding of the nuclear content, which is absent in hematopoietic cells. And there are a lot of fat spaces. These are the fat spaces in between the hematopoietic cells. Such things will help us in differentiating the hematopoietic cell from a cluster of a carcinoma. These are the various histiocytes. The normal histiocytes that we get. This is something generally we don't get it in this form. We get it in this form. The spindle-shaped cell with the processes going all around. And apart from that, we can see erythrophagocytosis or hemophagocytosis. Apart from erythroid cells, other cells can be seen. These are also histiocytes, and most commonly these are the C-view histiocytes seen in cases of CML or wherever there is a rapid turnover of bone marrow. It can sometimes be seen in cases of thalassemia also. And here again is a histiocyte which shows hemophagocytosis. So I'll end this today with this. What I would say, to sum up, I would say that once we have planned a marrow, get the clinical details of the patient, go through it first, look at the peripheral smear, and then you decide yourself whether marrow is needed or not. whether you have a previous peripheral smear or not, at the time of doing a marrow, you always should take a peripheral smear. If you can take a CV sample, well and good, otherwise take it from a finger prick. Always look for marrow particles, and on the trail of the marrow particles, you should start counting. Start looking from the scanner so that you can get a whole view, the cellularity, the distribution of cells, presence of megakaryocytes, and other things. Always do a 500 cell differential. Look out for other cells, that is the plasma cells and macrophages in normal marrow also, because that will help you in honing your skills to identify them when you need to. And in suspected disease of focal marrow involvement, like the metastatic deposits or a lymphoma infiltrate, we should always do a bone marrow biopsy along with an aspirate, so that we can reach a diagnosis. That would be it, sir.
Okay, I think this is one of the best presentations on bone marrow for the basic first year and second year students. I think I have myself gained a lot. Uh,
I,
any
I
questions?
deliberately
I
kept
see Jyoti has raised her hands. Jyoti, Dr. Jyoti Prabhu, you have raised your hands. Anyone who wants to ask a question can raise their hands. Dr. Manoj, okay, Dr. Manoj, yes.
Sir, what is the differentiation between multilobulation and multinucleation
see, multilobulation, you will in
versus multinucleation?
yeah, in multinucleation, all there will be separate nucleus. They will be away from each other. You can count them separately. In lobulation, they will be connected to each other by a thin strand, thin or thick strand, it depends. Uh, Whether they are lying apart from other, the lobes will be connected to each other by a strand. So when they are not connected and lying apart, that is known as multinucleation. If all of them are connected to each other by strands, it is known as multilobulation.
Then, sir, one more question. What is the difference
Yes.
between monoblast and myeloblast?
Monoblast and myeloblast. See,
How to differentiate?
yeah, the myeloblast generally will have the amount of cytoplasm is less in myeloblast. The nuclear size is also less. The cytoplasm is bit basophilic, and we can get granules. That is, the primary granules are seen in blasts, in myeloblast. In monoblast, the size is generally larger than of that of a myeloblast. The nucleus is a bit lacy. Most of the time, indentation can be seen. There is cytoplasmic vacuolation can be seen. Other than that, the color of the cytoplasm of a monoblast is grayish or sky blue to grayish. But that of a myeloblast, it is we can say pinkish, a bit pinkish to basophilic and with granules. Granules may sometimes, very occasionally, be seen in monoblast, but they are of very fine granules and they are of lilac color, vis-a-vis in myeloblast, in which they are the primary granules or the pink color granules.
Thanks a lot, sir.
Uh, one question from my side. I am from the era when they used to take a lot of samples from sternum, and now we have
Yes,
also
sir.
shifted to taking samples from posterior iliac spine. I mean, I
Sure.
remember from sternum also the samples used to come very easily, and I have never seen
Because if,
anyone
uh,
penetrating any further.
yes, sir. I have also never seen that, because when I learned doing a bone marrow, I also learned it from sternum. I have must have done more than 5,000 marrows till now, and I would say initially 1,000 I must have done it from sternum, and after that I shifted to posterior superior iliac spine. It becomes a very easy for us, because once a patient is lying straight, even if you cover his head, the eyes, you can see the needle going inside his sternum. That is a bit traumatic for the patient. Although I accept it's very easy, it's easy for us. We can quick in, quick out as a thing that we can do from sternum. It's very, very easy. Hardly takes less than 5 minutes.
Less than 5 minutes, and the sample yield is so wonderful from.
Very much of the sample yield. So there have been studies on the sample yield from various parts, and in early stages there not much difference is there. But as we grow older, the sample yield is better from the ilium, that is the posterior superior iliac spine. It is a bit better than that, although not much of a difference when we are going to diagnose a leukemia or a multiple myeloma or an